Welcome to this new episode. Today, we're diving deep into pediatric skin infections and disorders, exploring the complex roles the skin plays, not just as a protective barrier, but also as a sensory organ, a regulator of body temperature, and a vital warning system.
Yeah, it's fascinating how the skin is involved in so many functions, and when it comes to children, the range of dermatological conditions is really broad. From infectious diseases to inflammatory and environmental disorders, each has its own unique challenges in terms of pathophysiology and management.
Absolutely. And what really stands out is the critical role nursing care and education play, not only in managing these conditions, but also in preventing their spread and minimizing complications.
Right, so let's start with bacterial skin infections, which are quite common in pediatrics. The skin normally hosts a variety of bacteria, including pathogenic staphylococci and streptococci. But whether these organisms cause disease depends on factors like their invasiveness, toxicity, the integrity of the skin barrier, and the host's immune defenses.
Exactly. And children with immunodeficiencies, malignancies, or those on immunosuppressive therapy are particularly vulnerable to these infections.
One of the most common bacterial infections we see is impetigo contagiosa, caused by Staphylococcus. It typically begins as a reddish macule, progresses to vesicles, which rupture easily, leaving behind those characteristic honey-colored crusts.
Yeah, and it's highly contagious, especially among toddlers and preschoolers. Management involves careful removal of crusts using boro solution compresses, topical bactericidal ointments, and systemic antibiotics like penicillin for severe or extensive cases.
And it usually heals without scarring unless there's a secondary infection. What's interesting is how easily it can auto-inoculate and spread, especially in kids with eczema.
That's a good point. Then there's pyoderma, which is a deeper infection involving both staphylococci and streptococci. It extends into the dermis and often presents with systemic symptoms like fever and lymphangitis.
Management here includes antibacterial cleansing, wet compresses, topical mupirocin, and systemic antibiotics. And again, it's contagious and can heal with or without scarring.
Moving on, folliculitis, furuncles, and carbuncles are all follicular infections caused by Staphylococcus aureus. Folliculitis is a superficial infection of the hair follicle. Furuncles are larger boils with more redness and swelling, and carbuncles are even more extensive, involving multiple follicles.
Systemic symptoms like malaise can occur in severe cases. Treatment focuses on skin hygiene, warm compresses, topical and systemic antibiotics, and incision and drainage for severe lesions.
A critical nursing point here is to never squeeze these lesions. Squeezing can worsen the infection or spread it further.
Definitely. Then we have cellulitis, which is inflammation of the skin and subcutaneous tissues, caused by streptococci, staphylococci, or Haemophilus influenzae. It presents with intense redness, swelling, firm infiltration, and often lymphangitis.
Systemic symptoms like fever and malaise are common. Treatment includes oral or parenteral antibiotics, rest, immobilization, and hot compresses. Hospitalization may be necessary for severe cases, especially if the face or joints are involved.
And then there's staphylococcal scalded skin syndrome, caused by S. aureus toxins. It leads to epidermal peeling and bulla formation, mainly in infants who are vulnerable to fluid loss and secondary infections.
Treatment involves systemic antibiotics and gentle skin care with saline or boro solution compresses.
What's fascinating is the walling off process in staph infections, where abscess formation makes treatment more difficult. The abscess acts as a bacterial reservoir, complicating eradication.
Right, and this ties into the rise of community-acquired MRSA infection, which have become a significant concern, especially in crowded settings like daycares, prisons, and among indigenous populations.
The lack of indoor piped water and household overcrowding in some communities directly impacts hygiene and increases MRSA prevalence.
Nursing care is crucial here. Preventing self-inoculation by discouraging touching lesions, strict hand hygiene, using separate towels and clothing, daily laundering in hot water, and avoiding sharing razors.
And families should be advised to seek medical attention promptly if fever develops or lesions worsen after 48 hours of treatment.
That's a comprehensive overview of bacterial infections. Shall we move on to viral skin infections?
Yes, viruses are intracellular parasites that hijack host cell machinery to replicate. The epidermal response can be inflammation and vesiculation, like in herpes simplex, or proliferation as seen with warts.
Starting with verruca, or warts, caused by human papillomavirus. They're firm, rough papules, often on exposed areas like fingers and face. Treatment varies and can include destructive methods like cryotherapy or curettage, but these can leave scars.
Warts are autoinoculable and may enlarge with irritation, so patients need to be cautious.
Then there's herpes simplex virus types I and II. They cause grouped vesicles on mucocutaneous junctions, lips, nose, genitalia, that dry, crust, and heal in about 8 to 10 days.
Management includes topical antivirals like penciclovir, oral antivirals such as acyclovir or valacyclovir, and prevention of secondary infection. Sunscreens help prevent cold sore flares by protecting against UVA and UVB light.
Varicella zoster virus causes chickenpox and shingles. The vesicular eruptions follow dermatomes, often preceded by neuralgic pain. Treatment is symptomatic with analgesics, mild sedation, and antivirals like acyclovir.
Postherpetic neuralgia is rare in children, which is fortunate.
Molluscum contagiosum is another viral infection, caused by a pox virus. It presents as flesh-colored papules with a central umbilication, common in school-aged children.
Usually self-limited, treatment is reserved for troublesome cases, often involving topical anesthetics and curettage.
Moving on to dermatophytoses, or fungal infections. These are caused by filamentous fungi invading the stratum corneum, hair, and nails. They're superficial infections designated by tinea with location-specific names.
Tinea capitis affects the scalp, causing scaly patches and alopecia. It can cause inflammatory carrions in severe cases. Transmission is person to person or from pets.
Treatment includes oral griseofulvin, or ketoconazole, selenium sulfide shampoos, and topical antifungals like clotrimazole.
Tinea corporeus presents as round, erythematous scaling patches with central clearing, often from animal origin. Treatment involves oral and topical antifungals applied beyond lesion margins.
Tinea cruris, or jock itch, affects the groin and is pruritic but rare in preadolescence. Tinea pedis, athlete's foot, involves interdigital maceration and fissuring, rare in children but increasing with plastic shoe use.
Candidiasis is common in moist areas, especially diaper dermatitis and mucosal infections. It presents with inflamed areas and white exudate.
Treatment includes topical or systemic antifungals like nystatin or fluconazole.
Nursing care emphasizes hygiene, avoiding sharing personal items, treating pets, and adherence to prolonged antifungal therapy. For example, grisofulvin should be taken with high-fat meals for better absorption.
And importantly, medication should be continued even after symptoms subside to prevent relapse.
Now, mycotic or deep fungal infections are systemic and can invade viscera and skin. Examples include blastomycosis, cryptococcosis, and histoplasmosis.
These are usually acquired by inhaling spores from soil and are not contagious person to person. Cutaneous lesions are granulomatous and chronic.
Treatment involves systemic antifungals like amphotericin B and ketoconazole, and recognizing geographic and immunosuppression risk factors is key.
Shifting gears to contact dermatitis, it's an inflammatory skin reaction to chemical or natural substances causing hypersensitivity or irritation.
It commonly affects the face, neck, hands, forearms, genitalia, and lower legs. We distinguish between primary irritants, which affect any skin, and sensitizers, which affect only sensitized individuals.
Common agents include plants like poison ivy, oak, and sumac, metals like nickel, animal irritants like wool, synthetic fabrics, dyes, cosmetics, and soaps.
The dermatitis from poison ivy, oak, and sumac is caused by urushiol oil. Sensitivity develops after 1 or 2 exposures, and the oil penetrates the epidermis rapidly, binding to the dermis and triggering an immune response.
The reaction manifests as redness, swelling, itching, and blistering. Nursing care involves immediate cleansing with isopropyl alcohol or vinegar, followed by soap and water to remove urushiol.
Harsh scrubbing or soaps that spread the oil should be avoided. Contaminated clothes, tools, and pets must be cleaned.
Symptomatic treatment includes calamine lotion, boro solution compresses, oatmeal baths, topical corticosteroids for inflammation, and oral corticosteroids for severe cases.
Preventing scratching is important to avoid secondary infection.
Medication-related skin reactions are next. The skin is the most commonly affected organ by adverse drug reactions.
These reactions can be toxic, allergic, or idiosyncratic, ranging from mild rashes to severe epidermal necrosis like Stevens-Johnson syndrome.
Onset can be immediate or delayed, with prior sensitization accelerating the reaction. Management usually involves discontinuing the offending drug.
Antihistamines and corticosteroids may be used for symptom relief. Nurses play a key role in taking thorough medication histories, early recognition, withholding suspected drugs, and educating patients.
IV medications have a higher risk of reactions. If suspected, the medication should be stopped, but the infusion maintained with saline.
Moving on to arthropod bites and stings, these cause mild to moderate discomfort in children.
Arthropods include insects and arachnids like mites, ticks, and spiders. Most spiders in Canada are harmless, except the brown recluse and black widow.
Brown recluse bites cause necrotic ulcers and systemic symptoms like fever and joint pain. Treatment includes antibiotics, corticosteroids, analgesics, and sometimes skin grafts.
Black widow bites cause local and systemic pain with autonomic symptoms. Antivenoms, muscle relaxants, steroids, and analgesics are used.
Hymenopteran stings, bees, wasps, inject venom via a barbed stinger. Removing the stinger promptly is critical.
Hypersensitive children risk anaphylaxis and need epinephrine kits and medical ID bracelets. Nursing education on prevention, recognition, and emergency management is vital.
Scabies is caused by the Sarcoptes scabii mite burrowing into the stratum corneum.
Intense itching develops 30 to 60 days after infestation, or within 48 hours if previously sensitized. Lesions are thread-like burrows with a black dot representing the mite.
Distribution is mainly intertriginous areas, hands and wrists in older children, feet and ankles in infants.
Treatment is permethrin 5% cream applied from neck down, including between fingers and toes, left on for 8 to 14 hours, then washed off.
All close contacts must be treated simultaneously to prevent reinfestation. Bedding and clothing should be washed in hot water and dried hot.
Itching may persist for weeks. Antihistamines and soothing lotions help.
Pediculosis capitis, or head lice, is an infestation of the scalp by Pediculus humanus capitis.
The female lays eggs near the scalp, and itching is the primary symptom. Common sites are occipital area, behind ears, and nape of the neck.
Diagnosis is by visualizing nits firmly attached to hair shafts. Treatment includes permethrin 1% cream rinse or pyrethrin products, with a second treatment after 7 to 10 days.
Non-insecticidal options include dimethicone, isopropyl myristate, and St. cyclomethicone.
Manual removal of nits with a fine-toothed comb is essential. Environmental cleaning is limited to washing items in hot water or sealing in plastic bags.
Nurses should educate families to dispel myths, emphasize no exclusion from school, and prevent spread.
Bed bugs, or Cimicidae, are increasingly common due to travel. They hide in mattresses and furniture and feed at night, causing linear groups of itchy red lesions.
They don't transmit infections, but scratching can cause secondary infection. Treatment is symptomatic, and environmental eradication is challenging.
Nurses play a role in educating families on inspection, cleaning, and professional pest control.
Rickettsial diseases are caused by organisms transmitted by arthropods like ticks, lice, and fleas.
Diseases include Rocky Mountain spotted fever, epidemic and endemic typhus, rickettsial pox, and West Nile fever.
Clinical features include fever, rash, maculopapular or petechial, and systemic symptoms. Management involves vector control, antibiotics like tetracycline or chloramphenicol, and supportive care.
Lyme disease, caused by Borrelia burgdorferi via deer tick bite, is increasing in Canada but still relatively rare.
It has 3 stages: early localized with erythema migrans, disseminated with neurologic and cardiac involvement, and late with arthritis and chronic neurological symptoms.
Early treatment with antibiotics, like amoxicillin in children under 8, prevents complications.
Nursing care focuses on prevention, protective clothing, tick checks, cautious use of repellents. DEET is not for infants under 6 months, and prompt tick removal.
Animal bites are common in childhood, mostly from dogs and cats. Cat scratch disease is caused by Bartonella henselae, presenting as an erythematous papule and regional lymphadenitis.
Wound care involves copious irrigation with saline or lactated ringers, mild soap cleansing, pressure dressing, and elevation.
Medical evaluation is important for tetanus and rabies risk. Prophylactic antibiotics are indicated for puncture wounds or cosmetically or functionally sensitive areas.
Prevention through education on animal behavior and safe interaction is key.
Now, miscellaneous pediatric skin disorders. Diaper dermatitis is common in infants, caused by prolonged contact with urine, feces, soaps, and friction.
The pathophysiology involves increased pH, fecal enzymes, and increased skin permeability. Lesions appear on convex surfaces, sparing folds and chemical irritation. Candidiasis causes perianal inflammation with satellite lesions.
Nursing interventions include frequent diaper changes, air exposure, barrier ointments like zinc oxide, avoiding harsh soaps, and safe powder use. Cornstarch is preferred over talc.
Atopic dermatitis, or eczema, is a pruritic condition with hereditary allergy tendency. It has infantile, childhood, and adolescent stages.
Lesions vary by age and location, with intense itching leading to scratching and secondary lesions.
Management goals are hydrating skin, relieving pruritus, preventing flare-ups, and controlling infection.
Treatments include emollients, topical steroids, immunomodulators like tacrolimus and pimecrolimus, antihistamines, and phototherapy.
Nursing care involves assessing family history, lesion characteristics, educating on skin care, preventing scratching with short nails and gloves, avoiding irritants, managing environment, and supporting psychosocial needs.
Seborrheic dermatitis is a chronic inflammatory reaction, common as cradle cap in infants, with yellowish, oily, scaly patches on scalp, eyelids, ears, and nasolabial folds.
Treatment focuses on scalp hygiene, mild shampooing, and removal of crusts with a comb.
Finally, acne vulgaris is the most common adolescent skin condition, caused by increased sebum, follicular keratinization, bacterial proliferation, and inflammation.
It has significant psychosocial impact even when mild. Treatment includes general health promotion, gentle cleansing, avoidance of irritants, and medications like topical tretinoin, benzoyl peroxide, topical and systemic antibiotics, oral contraceptives for females, and isotretinoin for severe cases.
Nurses should assess distress, educate on treatment adherence, dispel myths, and caution against picking or squeezing lesions.
So to wrap up, pediatric skin disorders cover a broad spectrum of infectious, inflammatory, and environmental conditions. Understanding their pathophysiology and management is essential.
And nursing care and family education are pivotal in preventing spread, managing symptoms, and improving outcomes.
We also need to stay aware of emerging challenges like MRSA, resistant lice, and increasing bedbug infestations.
Plus, the psychosocial aspects, especially in conditions like acne and atopic dermatitis, must not be overlooked.
Ultimately, a multidisciplinary, patient-centered approach is key to effective care.
Thanks for joining us in this detailed exploration. We hope this deep dive enhances your understanding and practice.
Take care.